All right, so we have a patient that has come in complaining of gynecomastia. And what I'm going to do is I'm going to just go through the normal exam of a gynecomastia patient and identify the three things, namely any type of skin excess, what's going on with the breast tissue, and then the surrounding frame, which is usually fatty tissues. So what I look at, and I will always take the one that I see that is more challenging, and that's always going to be where the nipple is lower. You're pretty symmetric as far as where the nipple position is. So what I'm going to do is I'm going to draw the breast tissue, which is here to here, and then here to here. So what happens is this is the breast tissue, and you can see we get into some fatty tissue over here. Now what I'm going to do is I'm going to draw where the muscle is underneath it. So this is not always the easiest thing to find, because what will happen is when the breast tissue is gone, it's going to reveal where the muscle is underneath it. And sometimes you find that the nipple itself isn't really even on the chest, it's kind of starting to drop down. So I'm going to look, this is a xiphoid, and here is this patient's sixth rib. So right here. So you can see that actually we're doing pretty well. Now this is normally where the pec is, and I believe that will be the case. What we notice is that the nipple is above, which is fantastic. It's above by about 1.5 centimeters, which I love. We not uncommonly will run into times where we have to actually raise the nipple up a little bit to sneak it back onto the muscle. And that may be the case here, but I don't think so. I think we're doing well with it. What I outlined here is where the breast tissue is, and then where the pec muscle is. So this tissue that is here is really the breast tissue that has oozed over the pec muscle and is now on really the upper abdomen. So we need to, one is to get rid of that breast tissue, and then two, we need to get this to lay flat and then this to lay flat too. I call that the hockey stick. So creating the hockey stick. Again, the thing that we do have going for us is that the nipple is in a good position, I believe. We could be fooled because sometimes the origin of the pec is a little bit higher than we think. But normally this is the case, so bringing that down. So we have the breast tissue removed. We are, what I see is that we have this excess skin. And this is an uncomfortable thing to do, but what I will often do is ask the patient, can I ask you to have a seat, please?
Yeah, sure.
And then I'm going to have you do what I call the elbow to knee test, which is when you put your elbow on your knee and then you relax your chest. And what that does is it shows the relative amount of looseness within the skin. So if you're doing this with your wrists relaxed and you can see that the skin is falling off, which we have some of that, we know we're dealing with a skin excess. We'll treat that with a crescent, really removing as much skin as I can, yet still keeping the incision around the areola. And then sometimes I will do what I call a V to Y, where I will actually extend it a little bit and I will remove even a little bit more skin. It does leave a small vertical incision, but you won't see it. But what it does is it removes the excess tissue in both a vertical direction as well as a horizontal. So, because you have primarily vertical excess, but there's also this horizontal. And the impressive part about the V to Y is that it helps create this chest fold, because that's really what we're about. We're about creating chest definition. So if we just remove the volume and that skin just sags, that's not going to accomplish the result that we want. It will get rid of the volume, and that's what many patients and often surgeons think about, getting rid of the volume, but we really need to define the chest as much as possible without making big, long incisions. The final thing that I look at is what's going around with what I call the frame. So we have often fatty deposits here in the pre-axilla, often in the axilla. Your axilla looks great. You've got a nice dome. Some people have it where it looks like there's a pair of socks stuffed into their armpits. And you do have the breast roll. So you don't have the axillary fat, but you do have this breast roll that we would want to address.
Yeah, I can't get rid of it. No matter how much I work out, it just doesn't go away. Yeah, it's hard.
And it's a great opportunity to do that. So we're going to be removing this breast tissue, and then we'll be going in and actually managing the excess fat here.
Is that just a small circular incision on the side? Or
No, it'll be
do the same.
Great question. No, it's done through the same incision.
Okay.
So it doesn't add any more incisions to it. The other thing that we will want to do is to actually create the frame. So I look at, you can see where you have this inscription here. So everything above this, again, it's to define the chest. It's not just to remove the breast tissue, but it's to define the margin as if we've a picture and we are creating this frame around it. The thing that I will say is that when we have skin excess and we're not exactly sure where the nipple will fall in relationship to the pec, it is possible that in the future, say in 6 months, we will need to actually bring the nipple up a little bit if we find that the nipple is low set, if it's at the bottom of the pec or sometimes even falling off. So I will do this, and interestingly, it's part of a anti-aging, because to me, every 5 years over the age of 45, you should probably have a little bit of that skin removed just to tighten it over time, because a loose chest is really tough on most men.